Hello, dear students. I'm Dr. Mushfig Orujov, the Associate Professor of Department of Pathological Anatomy of Azerbaijan Medical University. Now we start our lecture.
The topic of our today's lecture will followings: the nosology, cardiovascular pathology, and cerebrovascular pathology. The plan of our today's lecture is nosology, that we will discuss about the etiology and pathogenesis of the diseases and nomenclature and classification of the diseases. Cardiovascular pathology, about the ARTERIOSCLEROSIS, hypertension, and ischemic heart disease we have discussing. And finally, the cerebrovascular pathology, that include the ischemic cerebral stroke, hemorrhagic cerebral stroke, and hypertensive hemorrhagic pre-stroke change. Nosology, from Greek, it means the nosos, disease, logia, study of, is a branch of medicine that deals with classification of diseases. Diseases may be classified by etiology, pathogenesis, which the disease is caused by mechanism, or by symptoms. Alternatively, diseases may be classified according to the organ system involved, though this is often complicated since many diseases affect more than one organ. The coding systems of diseases. Several classifications of diseases have been historically proposed, and normally all of them assign the code to every supported disease. Some of them codify diseases following the path of the classification tree, and others, like the SNOMED, use a multi-factor classification system. The most common coding system in the World Health Organization ICD series, but there are other accepted classifications like Dokley, Landa, or SNOMED. Here you see the schematic illustration of the ICD-10 revision. As you see here, the diseases as grouped into the 22 nosological groups. And here I add the online version of the ICD-10 classification. For example, here when you are enter the acute myocardial infarction, you will find the following subcodings that regarding to the acute myocardial infarction. There are several principles of classification of the diseases. First, etiological classification. The diseases classified to the congenital and acquired diseases, and acquired diseases also divided to the infectious or communicable and non-infectious or non-communicable. A second, anatomical topographical classification. For example, the diseases of the central nervous systems, diseases of the digestive system, diseases of the respiratory system, and etc. According to the character of pathological process, there are inflammatory diseases, degenerative necrotic diseases, tumors, and other diseases. According to the clinical course, we classify the fulminant, acute, subacute, chronic, and chronic active diseases, in some cases latent, virus carrier, abortive, and other types. According to the intensity of clinical signs and the degree of severity, we can classify the mild, moderate, and severe types. According to the age and sex, we can classify the gynecological, pediatrical, internatal, perinatal, gerontological, and other diseases. According to the external environmental, life, geographical, professional, and other factors. There are professional, military, social, endemic diseases, ecological pathologies, etc. According to the accordance of pathogenetic or morphogenetic mechanisms, there are rheumatic diseases, specific diseases, autoimmune diseases, etc. Etiology is the cause of a disease. There are two groups of etiological factors, exogenic and endogenic. Pathogenesis of a disease is the biological mechanism or mechanisms that leads to the disease state. The term can also describe the origin and development of the disease and whether it is acute, chronic, or recurrent. The term from the Greek pathos, that meaning disease, and genesis, creation. We use in the medicine some terms like the syndrome, symptoms. Let we differentiate. What meaning the syndrome? Syndrome, from Greek, it means that concurrence is a set of medical signs and symptoms that are correlated with each other. There is no set common convention for the naming of newly identified syndromes. For example, you know the immunodeficiency syndrome, portal hypertension syndrome, thromboembolic syndrome, hepatorenal syndrome, etc. In the past, syndromes were often named after the physician or scientist who identified and described the condition in an initial publications. They are referred to as eponymous syndromes. For example, Angelman syndrome is a neurodevelopmental disorder characterized by severe intellectual and developmental disability, sleep disturbance, seizures, jerky movements, frequent lower or smiling and usually happy demeanor. Some of the syndromes has become to the nosological unit of the diseases. For example, the AIDS, Goodpasture syndrome, Zollinger-Ellison syndrome, and etc. But what meaning the pathomorphosis? Pathomorphosis is a resistant changing of the clinical and morphological patterns of various diseases. Causes of pathomorphosis are complex and diverse. It is assumed the possible role of the natural evolution of the diseases, natural pathomorphosis we call, due to the evolution of pathogenic properties of the pathogen. However, the most significant and authoritative role of active preventive and treatment measures, especially antibiotic therapy, we call the therapeutic pathomorphosis. Modern active chemotherapy, hormonotherapy distort the picture of the disease, depriving its typical features. It is therapeutically due pathomorphosis dramatically change not only the picture of many diseases but also morbidity. They sharply change not only the overall morbidity and mortality but also during the pathology of individual diseases. Virtually disappeared some children's infection diseases. Scarlet fever, diphtheria have become rare diseases. Changed the incidence of infection diseases of adults. Lobar pneumonia gave earlier greater mortality, has become a rare diseases like typhoid fever, typhus, and other diseases. All this change, the general panorama of diseases occurred pathomorphosis, all nosological systems that better be described as mesomorph. For example, the mesomorph within specific groups of diseases can be change of relations in the frequency of different forms of cancer. A few decades ago, lung cancer was a rare disease. It takes the second place after gastric cancer. Medical diagnosis, that abbreviated as the DX or DS, is the process of determining which disease or condition explains a person's symptoms and signs. It is most often referred to as diagnosis, with the medical context being implicit. The information required for diagnosis is typically collected from a history and physical examination of the person seeking medical care. Often, one or more diagnostic procedures, such as a diagnostic test, are also done during the process. Diagnosis is often challenging because many signs and symptoms are non-specific. For example, redness of the skin, erythema, by itself is a sign of many disorders and thus doesn't tell the healthcare professional what is wrong. Thus, differential diagnosis, in which several possible explanations are compared and contrasted, must be performed. This involves the correlation of various pieces of information followed by the recognition and differentiation of patterns. Occasionally, the process is made easy by a sign of symptom that is pathognomic. Here you see the two examples of the medical report diagnosis. One of them the draft for the surgical pathology report that here that include the histopathological diagnosis, and here were taken from one the hospital about the left maxillary soft tissue, the lesion that's diagnosis as the fibroma giant cell type, or another disease the verruciform xanthoma. Let we discuss about some kinds of the disease that specifically classified. What makes the main primary disease? It means that disease which leads to death or cause the entering the patients into hospital. The morphologic signs may be shown in pathological diagnosis after the main disease. For example, the hypertension. First, we write the hypertension because it is the autopsy material, autopsy diagnosis. We can in the bracket write the weight of the heart, thickness of the lateral wall of left ventricle, the thickness of the right ventricle. Competitive diseases. Each of these diseases may cause death separately. For example, in the same patients has both the myocardial infarction and abundant carcinoma metastasis in lungs. When we do the autopsies, we found these two features. The sequence of diseases determined for the clinical importance. Combined diseases do not cause a death separately, but when they present in same patients, accelerate each others and cause a death. For example, the rupture of cerebral vascular aneurysm after slightly trauma. Background disease, the disease or pathological process which leads to development of main disease. For example, the main disease is myocardial infarction. The background plays a role the ATHEROSCLEROSIS of coronary artery of heart, or the main disease of gastric cancer. The background disease for the gastric cancer is chronic atrophic gastritis. The background disease notes after main disease in pathology report. Second disease, another independent nosological disease that develops as a late result of previously existing disease, such as the development of adhesion disease after the intestinal surgical resection. Accompanying disease present in the cadaver and doesn't any relation with death. For example, in the patient with the gastric ulcer has also the cholelithiasis, the stone disease of the gallbladder. Complication of disease is an unfavorable evolution or consequence of a disease, health condition, or a therapy. The disease can become worse in its severity or show a higher number of signs, symptoms, or new pathological changes, become widespread throughout the body, or affect other organ systems. A new disease may also appear as a complication to a previous existing disease. One of these complications causes the death of patients. For example, the perforation of stomach wall in gastric ulcer and development of peritonitis. Clinical anatomical epigraphies are an important part of the pathological autopsy protocol and includes followings: cause, condition, and mechanisms of development of the disease, background cause to the development of the disease, corresponding morphological and functional change occurred in the organism from starting of disease until his finish, mechanisms of disorder of the relation between organs and systems, explanation of emerged clinical symptoms and syndromes and their morphological basis, developmental mechanisms of the complications of main disease, conducting diagnostic and treatment procedures, their positive and negative effects, iatrogenesis, malpractices, influence of conducted medical manipulations to the course of disease, shortcomings during the writing of medical documents, especially of the medical history, and results of the comparative analysis of clinical and pathological changes. Let's now we discuss about the iatrogenesis. Iatrogenesis, from Greek, it means the brought forth by the healer, iatros physician, genesis creation, refers to any effect on a person resulting from any activity of one or more persons acting as healthcare professionals or promoting products or services as beneficial to health that doesn't support the goal of the person affected. For example, anaphylactic shock during the hemotransfusion, dysfunctional atrophy of adrenal cortex or medulla after the long-term therapy of viral hepatitis by the adrenocorticotropic hormones, anemia during the radiation therapy, immunodeficiency syndrome during the treatment with immunosuppressants, hypoxia and asphyxia during the anesthesia, and etc. Half of the iatrogenias occurs due malpractices. Discrepancies between clinical and pathological diagnosis. Sometimes the clinical diagnosis as a whole and sometimes the main disease as well as any complication or the accompanying disease is not confirmed in pathological anatomical examination of the cadaver and it is considered as a clinical physician error. It's called the discrepancies between clinical and pathological diagnosis. If the gross medical error, fault, or negligence are found in autopsy, these facts are noted in the clinical anatomical epigrisis and in the medical history, are informed to the administration of the medical institution, and are discussed in the clinical anatomical conferences in hospitals. The facts, as required by the pathologist, can be given the appropriate law enforcement authorities. The classification of the medical errors. According to the character, there are tactical medical errors and technical medical errors. The tactical medical errors, the treatment process is not properly organized. Technical medical errors, failure of the preparation of medical records. Dependent on the stage of occurrence, there are three types of the medical errors: diagnostic, treatment, and preventive medical errors. Third, depending on the reasons of occurrence, there are two types: the objective and subjective medical errors. Objective medical errors, the shortcomings in the organization of health and medical services, absent the continued medical education, and etc. Subjective medical errors depended on the doctor's personal characteristics, tactical and technical mistakes, inexperiences, lack the necessary level of knowledge and required level of qualification, and others. There are three categories of discrepancies between clinical and pathological diagnosis. First category: failure to identify of the disease before the patient is taken to the hospital, or the wrong clinical diagnosis due to the severity of the patient's condition, extension of the pathological process, and very short duration of the patient's hospital stay. Second category of discrepancies: failure to identify the disease at the hospital, the incorrect clinical diagnosis as a result of the absence of appropriate and available examinations. However, even if the correct diagnosis of the disease could have a decisive influence on the course of the patient's death, the proper diagnosis could be made in clinic. Third category: the cause of fatal outcome of the disease is failure to correct diagnosis by a doctor and due to the absence of a proper doctor's or the medical doctor's tactic selection. Now, the second part of our lecture regarding the cardiovascular pathology, and we will discuss about the three diseases: the arteriosclerosis, hypertension, and ischemic heart disease. Let's first remember the structure of the blood vessels. Here you see the schematic diagrams and the histological structure of the large vessels. Here is the general schematic illustration of the vessel wall, that they have the three tunics: the tunica intima, the inner layer, the tunica media, especially include the elastic fibers and smooth muscles that they differ regarding the vessel types, and tunica adventitia. Here you see the wall of the elastic artery, that the tunica media of the elastic artery consists of the many numbers of the parallel located elastic lamella. And all of the blood vessels, they covered by the endothelial cells, that they play a very important role of the blood vessel functions. There are following types of the arteriosclerosis. The term of the sclerosis you remember from the pathological anatomy. One course, that sclerosis, the formation of the rough abnormal connective tissue. First, the metabolic arteriosclerosis or the atherosclerosis, arteriolosclerosis or hyalinosis at hypertension, inflammatory arteriosclerosis, toxic arteriosclerosis, allergic arteriosclerosis, primary mediocalcinosis of arteries, and senile arteriosclerosis. The term of the arteriosclerosis, it describes the formation of the development of the sclerotic tissue in the wall of the arteries. Now let's discuss about the atherosclerosis. It is a specific type of arteriosclerosis affecting primarily the intima of large and medium-sized muscular arteries. Chronic inflammatory response in the walls of artery develops here. It is progressive slowly, a buildup of the fat cholesterol within the artery wall, characterized by intimal lesions called the atheromas, atheromatose, or fibrofatty plaques. The common sites of the atherosclerosis are abdominal aorta, coronaries, popliteal artery, the internal carotid arteries, the vessels of the circle of Willis, where the turbulence flow or the lamellar flow of the blood change to the turbulence flow in places that the blood vessels, they branch into other vessels. There is factors of the atherosclerosis. First, the unhealthy blood cholesterol levels. You know about the lipoproteins, cholesterol from the biochemistry course. This includes the high low density cholesterol, sometimes called the bad cholesterol, and low high density cholesterol, sometimes called the good cholesterol. Then high blood pressure. Blood pressure is considered high if it stays at or above 140/90 mmHg over time. Then smoking, insulin resistance, diabetes, overweight or obesity, lack of physical activity, unhealthy diet, the foods that are high in saturated and trans fats, cholesterol, sodium, and sugar. Older age. In men, the risk increases after age 45, in women after age 55. And family history of early heart disease. Your risk for atherosclerosis increases if your father or brother was diagnosed with heart disease before 55 years of age, or if your mother or sister was diagnosed with a heart disease before 65 years of age. There are some theories of atherosclerosis formation. First, the thrombogenic theory by Duget and incrustation theory, Rokitansky, response to injury of the endothelial cells theory, immunological theory, hematological theory, monoclonal theory, viral theory, inhibition theory offered by the Virchow. It means that infiltration of plasma components to the vascular wall, alimentary infiltration theory by the Anishkov and Kalatov, increasing of alimentary cholesterol level in blood, receptor theory, and last three theory are completed historical chronological sequence and was formed the lipoprotein theory. Let now we repeat our knowledge about the lipoprotein metabolism in organism from the biochemistry course. Chylomicrons, you know that in the enterocytes there are the chylomicrons that they consist of the more triglyceride and less cholesterol. Very low density lipoproteins, VLDL, are formed in the liver, transferred the lipids from hepatocytes into the blood. They consist of the triglyceride and cholesterol. Medium density lipoproteins, they cholesterol pre-base. Low density lipoproteins, 70% of blood proteins, that they consist of the cholesterol and apoprotein B protein, ApoB 100 protein. Low and very low density lipoproteins are atherogenic lipoproteins, as we call the bad cholesterol, but high density lipoproteins anti-atherogenic, or the good cholesterols. High density lipoproteins forms in cells that participated in removing and additional lipids from cell and passing them to the medium density lipoproteins. Apoprotein is a protein in the lipoproteins. Normal level of cholesterol in blood is 20 milligram per liter, and the ratio of the HDL to the LDL equal the 1 to 4. So the low density lipoprotein cholesterol deliver cholesterol to peripheral tissues. The good cholesterol, the high density lipoproteins, mobilizes cholesterol from developing and existing atheromas and transport it to the liver for excretion in the bile. So we discussed about some theories about the cholesterol atherosclerosis formation. The current hypothesis is response to endothelial cells injury that initiated by endothelial dysfunction. That the main components of the plaque, fibrofatty plaque that forms in the wall of the arteries during the atherosclerosis, they include the lipid-containing macrophage, extracellular matrix elements, and the cells, and also the proliferating smooth muscle cells. And here you see the schematic illustration of the fibrofatty plaque, that they include the macrophage, that lipid-laden macrophage, will call it the xanthone cells, the smooth muscle cells. The pathogenesis of the atherosclerosis. During the atherosclerosis, first the endothelial cells undergo the damage, but their cause not completely understood. The two most important causes of the endothelial dysfunction known: first, the hemodynamic disturbances and hypercholesterolemia. Inflammation is also an important contributor. And here you see the injury to the endothelium, then the chronic inflammatory response. Here you see the activation of the T cells by the cytokines, that they stimulate the smooth muscle cells that they're located in the media, and they start to proliferate, they migrate from the media to the intima. You see here the migration of the smooth muscle cells, then the proliferation of the smooth muscle cells in the intima, the excess production of the extracellular matrix by the fibroblasts, and the enhanced lipid accumulation in the intima. And you see that the macrophage that engulfed the cholesterol, lipids that became to the xanthone cells. here. Also the illustration of the formation of the fibrofatty plaque. Here you see the normal blood vessel. Here you see the starting the endothelial injury with the adhesion of the monocytes and platelets, the migration of the monocytes and smooth muscle cells into the intima, and smooth muscle cell proliferation and the extracellular matrix production. And here finally we do the well-developed the atherosclerotic plaque. We divide two periods of atherosclerosis as the microscopically and microscopically. Macroscopic periods of atherosclerosis, there are four periods. First, the fatty spots or the fatty streaks, present nearly universally in children. They do not cause any disturbance in blood flow. However, they may be precursors of atherosclerosis. Fatty streaks begin as multiple yellow flat spots, fatty dots, which are less than 1 mm in diameter. Subsequently, they merge into elongated 1 cm long and longer fatty streaks. They are composed of lipid-filled foam cells or the xanthum cells with T lymphocytes and extracellular lipids. Second period we call the fibrous nodules, that is symmetrical whitish yellowish solid consistency. The transverse diameter is less 1 cm. Nodules are narrowed to the vascular lumen that we classify to 10%, 25%, 50%, 75%, and 90%. Then this is the wound formation period for formation of the atheroembolism. The content of the atherosclerotic plaque, they can cause the embolism. And finally, the calcium salts, they sedimentate into the wound, and here forms the arteriocalcinosis, the destruction of the vascular wall. Here we do the plaques that the diameter vary between 0.3 to the 1.5 diameter, but they can merge to form the larger masses. And here you see the fatty streak. And here you see the fatty streak in the wall of the arteries. Now let we discuss about the microscopic periods of atherosclerosis. First, prelipidic period is the latent period of atherosclerosis, increasing the permeability of endothelium and basal membrane, mucoid swelling of intima, destruction of basal membrane, elastic and collagen fibers are found here. This we call the microscopic change. Lipoidosis, this is the second period, that focal infiltration of lipids and the lipoproteins and presence of the xanthum cells that macrophage engulf the lipids, but this process is irreversible process. Third period, liposclerosis, that they continue to chronic dystrophy, chronic hypoxia, sclerosis, and formation of the fibrous nodules. Fourth period, arteriomatosis, the xanthum cells, that the macrophage that engulf the lipids and the smooth muscle cells inside the fibrous nodule are ruptured, necrotized to form a pastidized detritus mass with the porridge-like structure. The detritus mass that include the free lipoproteins, plasma proteins, natural lipids, and cleavage products of collagen and elastic fibers, commonly we call the atheroma or the atherosclerotic nodule. The fifth and sixth periods, the macroscopic last periods, the wound formation and atherocalcinosis. Here you see the microscopically the macrophage-derived foam cells in the intima and the atherosclerotic nodule in the wall of the artery that they narrow the vessel lumen. The clinical complications of atherosclerosis are the myocardial infarction, cerebral infarction, aortic aneurysms, mesenteric occlusion, and peripheral vascular disease, such as the gangrene of the legs. Morphological changes that are seen on macro and microscopic levels in atherosclerosis are the neovascularization, the formation of new blood vessels, calcification, hemorrhage, fissure, ulcer, thrombosis, medial thinning, cholesterol microemboli, and aneurysmal dilatation. Here you see the illustration of the outcomes of the atherosclerosis. Here the preclinical phase, usually in the young age. We discussed with you the formation of the fatty streaks, that they continue to the fibrofatty plaque and the advanced and vulnerable plaque. But here this is the clinical phase, usually middle-aged to elderly patients. We see we do the formation of the aneurysm and the rupture of the blood vessels, occlusion by thrombosis, and the critical stenosis. Now let's discuss about the hypertension. There are two types of the hypertension, the essential and symptomatic, or we call the idiopathic or primary hypertension and secondary hypertension. The idiopathic hypertension has no identifiable cause. This chronic disease characterized with stable high level of blood pressure, but secondary hypertension is emerging as one of the signs of other disease. There are four groups of diseases that cause the symptomatic hypertension. First, the renal disease, nephrogenic and vasorenal hypertension, central nervous system diseases, neurogenic hypertension, endocrine diseases, and vascular diseases. Etiology of chronic hypertension: the nervous tensions, tobacco smoking, hypodynamia, obesity, heredity, salted food, sex, and age. Here you see the comparison between the chronic or benign hypertension or the malignant hypertension, we call is as the hypertensive crises. The etiology of the chronic hypertension mainly is idiopathic, but of the etiology of the malignant hypertension is mainly symptomatic. The age, the chronic or the benign hypertension usually absent in the young persons under 45 years old, while the hypertensive crisis is forming until 25-35 years old. The chronic hypertension mainly affect the males than males, but the hypertensive crisis equal in the males and females. The 55% of the earth population is sick by the chronic hypertension, but the hypertensive crisis are rare. The cause of the chronic hypertension continues for many years, but the hypertensive crisis continues for 1.5 years. The diastolic pressure is 90 to 120 mm Hg in the chronic hypertension, but in the malignant hypertension it is 130, more than 130. Hypertensive crisis, the clinical features of the hypertensive crisis or the malignant hypertension: the high blood pressure, diastole is higher than 120-130 millimeter Hg, weakening eyesight, dizziness, and hematuria. Acute spasm of arterioles, destruction of basal membrane of intima, plasmorrhea and edema in the wall of arterioles, fibrinoid necrosis in the wall of the arterioles, thrombi in the vascular lumen, and in the kidney, they results the malignant nephrosclerosis of FAR. But the chronic hypertension, they continue in the three periods. First, the preclinic period, or the transitional or functional or transitory. Second, period of dispersed vascular change, and third, period of secondary change in organs. The first period, change in vascular wall and heart. In the arterioles, we found the plasmarhagia and mucoid swelling in the intima, narrowed of vascular lumen. In the arteries, hypertrophy of elastic membrane, atherosclerotic change, but in the wall of the heart, the concentric hypertrophy of left ventricle. In the second period, the arterioles, the wall of the arterioles affected by the arteriosclerosis and hyalinosis. You have remembered that the hyalinosis, the marker of the morphological marker of the hypertension, the hyalinosis of the arterioles. Arteries, we can find the atherosclerosis in the all of type the arteries and elastofibrosis, but in the heart the change they became the deeper, the core bovine and the parenchymatous degenerations, and here develops the eccentric hypertrophy. In the clinics they are related with the decompensation phase. And third period, the change in vascular wall and the heart, the arterioles also they show the arteriosclerosis and hyalinosis. In the arteries the stenosing arteriosclerosis, the heart the arteriolosclerotic cardiosclerosis, necrobiotic change in cardiac muscle cells. There are three clinical morphological types of hypertension, chronic hypertension: cardiac type, cerebral type, and renal type. The cardiac form or type of hypertension we found in the wall of the heart the arteriosclerotic diffuse small focal cardiosclerosis, that if they became activated in the acute phase, they were complicated with the myocardial infarction. Or the cerebral form of the hypertension, atrophy of the cerebral cortex in neuron develops the degenerative change. The complication is hemorrhagic stroke that we'll discuss later now. And the renal form or the renal type of the hypertension, the arteriolosclerotic nephrosclerosis or primary shrinking of kidney, complication is uremia. In this slide, you see the microscope of the hypertension. This biopsy taken from the chronic hypertension diseases, and here you see the changing of the wall of the arterioles, the onion skin thickening of arterioles, and the narrowing of the lumen. But this biopsy taken from the malignant hypertension kidneys, and here you see the interlobular arteries and arterioles that demonstrate the densely eosinophilic material that representing fibronode necrosis of the vessel walls. This is the microscope of the malignant hypertension. And localization of the atherosclerotic change in the hypertension. The wall of the blood vessels forms the circular nodule, but in the atherosclerosis, the segmentary nodule. This is a very interesting comparison. In the final part, we will discuss with you about the ischemic heart diseases. The first, let we remember the anatomy of the heart. As you know, the human heart has the 4 chambers, 2 atria, and the 2 ventricles. Here you see the left side of the heart and the right side, and between the atria and the ventricles are the valves, and between the atria and the ventricular is the septa, is the interventricular septa, interatrial septa. Here you see the schematic diagram of the wall of the heart that consists of the 3 layers as the endocardium, myocardium. Endocardium is the very thin layer, myocardium, and the epicardium. The epicardium, this is the this is the pericardium. The from anatomy, you know that there are 2 types of the pericardium. First, the fibrous pericardium and the serous pericardium. Serous pericardium has the 2 layers, the parietal and the visceral pericardium. The visceral pericardium is also called the epicardium here. This is the pericardial cavity. Is a very fine histological section from the heart wall. That here you see the myocardium, the epicardium, the coronary artery section, and the coronary sinuses, and the section of the mitral valve. And the function of the heart, there are some functions. One of them is the pumping of the blood toward the organs. The second main function, they include the drainage of the venous blood from the organs. Very important function that in the heart diseases, this function, these features of the heart, that the drainage of the venous blood during the heart diseases, cardiac diseases, is complicated. And as you know, the heart has own the impulse conductor system that include this is the consists of the atypical cardiac muscle cells, the synoarterial node, the atrioventricular node, the his fibers that they finished with the Purkinje fibers, they reach the chorda tendineae. So also heart has some hormonal activity that they produce the natriuretic peptide and others. Now let me pass to the ischemic or the coronary heart disease. The ischemic or coronary heart disease is morphological and functional change in myocardium, occurs due to narrowing of lumen of coronary arteries and arterioles and absolute or relative dysfunction of myocardial blood supply, known as the ischemia. Ischemic heart disease occurs due to atherosclerotic change in the coronary artery or hyalinosis in the arterioles of the heart during hypertension that we discussed earlier. Sudden cardiac death is called death which occurs within a few 6 hours of cardiac symptoms. 250,000 deaths in the United States per year are caused by what is referred to as sudden cardiac death. Sudden cardiac death is also known as a massive heart attack, in which the heart converts from sinus rhythm to ventricular fibrillation. In ventricular fibrillation, the heart is unable to contract fully, resulting in lack of blood being pumped to the vital organs. Ventricular fibrillation requires shock from defibrillator shockable rhythm. Macroscopically and light microscopically, no cardiovascular change or cardiac sclerosis appear. And here you see the cause of the sudden cardiac death. The risk factors of ischemic heart disease, they divided to uncontrollable and controllable. Uncontrollable, they include the sex, the hereditary race and age, but controllable include the high blood pressure, high blood cholesterol, smoking, physical activity, obesity, diabetes, and stress and injury. And here they mean that physical inactivity, or the hypodynamia, or the less physical activity. The classification of the ischemic heart disease. There are acute and chronic ischemic heart disease. Acute ischemic heart disease also divided to the two diseases. The first, acute ischemic degeneration of myocardium and myocardial infarction. Chronic also divided to the diffuse small focal cardiosclerosis and post-infection large focal cardiosclerosis. Acute ischemic degeneration of myocardium, or we call the acute reversible ischemic lesion of myocardium, develops mainly due to long-term, up to 20-30 minutes, spasm of damaged coronary vessels. Major morphological change during histochemical examinations in cytoplasm of cardiac muscle cells are found. Reduction or complete disappearance of glycogen reserve, sharp decrease of activity dehydrogenase, oxidase, and phosphorylase enzymes, reduction of potassium ions or their total disappearance, increasing of sodium and calcium ions. During electron microscopic examinations in cardiac muscle cells are shown swelling and destruction of the endoplasmic reticulum, destruction and deformity, signs of apoptosis and other necrobiotic change in mitochondria, especially in their internal membranes and crystal. In this slide, we do the early acute myocardial infarction. Here you see the prominent pink contraction bands, and this is the increasing loss of cross striations. And some contraction bands are also seen, and their nuclei are undergo the karyolysis, and some neutrophils we can find between the cardiac muscle cells that they infiltrate into the myocardium. Myocardial infarction. Myocardial infarction is a necrosis of heart muscle secondary to prolonged lack of oxygen supply, ischemia. Myocardial infarction, or the myocardial ischemic necrosis, appears microscopically and macroscopically 6 to 18 hours after acute myocardial ischemia. There are 4 main causes of myocardial infarction: long-term, more than 20-30 minutes spasm of modified pathological coronary vessels of the heart is more common. At this same time, the long-term spasm of atherosclerotic vessels or hyalinized arterioles cause the absolutely blocking of blood supply of the area where they are vascularized. Second cause, the thrombosis of coronary arteries, develops as a result of injury of atherosclerotic nodules arising in coronary artery during the cardiac type of atherosclerosis and as a result of breaking of the integrity of vascular intima. Thromboembolism of coronary arteries occurs in very few cases. The thrombus comes to the artery from the left ventricle during endocarditis or from the initial part of the coronary artery. And fourth cause, the acting or the working of heart with modified pathological coronary vessels in physical tension. There are 2 morphological phases of myocardial infarction. First, the necrotic phase and sclerotic phase. The necrotic phase, the first signs of coagulative necrosis appear in 4 to 11 hours. After 18 hours, the infection appears macroscopically and microscopically. This phase lasts about 2 weeks. But after 10-14 days, the development of the connective tissue gradually starts about 4 weeks. It results in a scar formation. It's called the post-infection large focal cardiovascular. The heart restores this function within about 4 weeks. So in the cardiology, they call this as the golden 4 weeks. This slide illustrates the microscopy of the acute myocardial infarction in the interventricular septum. After several days, there is a yellowish center with necrosis and inflammation surrounded by hyperemic border. If you remember from the pathological anatomy 1, we discussed about the types of the necrosis and the infection, and we call is white infection with the hyperemic corolla. This is the demarcation zone. And the histology of the acute myocardial infarction. That here you see the necrotic area, that appearance of the neutrophils. The neutrophils seen at about 11-24 hours after onset of infection. And the infection area edematous and heavily infiltrated with the neutrophils, but here you see the intact, not damaged the myocardium. There is the sharp demarcation between the necrotic area and the normal area. Here you see the 3 days old acute infection with a heavy neutrophilic infiltrate, and the necrotic cardiac muscle cells are replaced by collection of neutrophils to initiate the process of inflammation and repair. And here also you see the microscopic features. the 1-day-old infection. We see the wavy fibers here, and the coagulative necrosis, the up to 3 days, as we seen in the previous slides, the neutrophilic infiltration, 1-2 weeks, the formation of granulation tissue, and finally the formation of the scar tissue. Let we continue our lecture with some classification principles of the myocardial infarction. There are some principles. First, according to the time, we classify 3 types of the myocardial infarction: primary, recurrent, and secondary, or the repeated myocardial infarction. Primary myocardial infarction is the first time affection of the myocardium of the patients. Recurrent myocardial infarction occurs before than 4 weeks after the primary infection. It usually results fatally because the myocardium is damaged and is not completely recovered after the primary myocardial infarction. But the secondary myocardial infarction has the good prognosis. It occurs 4 weeks after the primary myocardial infarction. Second, according to the localization in the different areas of heart, classified the lateral infection of left ventricle, posterior infection of left ventricle, anterior infection of left ventricle, infection of interventricular septum, and subtotal infection of myocardium. Third, classification according to the regional distribution of effects. We classified 4 types of infection. Subendocardial infection, the most common localization, occurs as a result of long-term spasm of coronary vessels. The necrotic area is confined to their inner 1/3 or half of the left ventricular wall, the endocardium. As the demarcation zone on the endocardial side cannot be formed, thrombus is formed to protect it. Because this thrombi breaks down and causes thromboembolic syndrome, this type is considered dangerous and severe. Second type of infection, subepicardial infection. On the epicardium overlying the necrotic area, develops the fibrinous inflammation. Third, intramural infection. Necrosis of single or small groups of muscle fibers in the mass of myocardium. Transmural infection caused by the complete persisting occlusion of the large arterial branch of the coronary arteries. In 90% cases, it results by thrombosis of vascular lumen. Necrotic area of the myocardium in the transmural infection is surrounded by demarcation zone from the lateral side, by fibrinous pericarditis in the epicardium from the outside, and by the thrombotic masses on the inside in the endocardium. Here you see the subendocardial and transmural infection. Some scientists they consider that all of the infects are the subendocardial infects, that they located in the inner 1/3 or to half of ventricular wall, that to decrease the circulating blood volume, that they results by the shock, hypertension, lysis, thrombus, and the circumferential. But if they continue, they can continue to form the transmural infection. This slide illustrates the acute myocardial infection of the anterior left ventricular wall and septum in cross section. This is near the transmural. Here you see the yellow center with necrosis and the demarcation zone, the surrounded the hyperemic zone, the zone of the demarcation. From the lateral side, if it is the transmural infection, we said that from the endocardium here will formation of the thrombus, and by the epicardium the pericarditis. And fourth principle, according to the size of the necrotic area. We classify the three types. The first, the small focal infection or the microinfection. The size of the necrotic area less than some millimeters. Then large focal infection and extensive infection. The size of the necrotic area sometimes they can reach to some centimeters. But subtotal infection usually occurs if more than half of the left ventricle is affected. Let's discuss about some clinical features and the diagnosis of the myocardial infarction. The severe chest pain, more powerful and intense than stenocardial pain, takes more than 50-20 minutes, is not relieved by nitroglycerin, radiates to the left scapula, shoulder, upper extremity, and jaw regions. Signs of acute heart failure, acute common venous hyperemia, edema in tissues and organs, hemorrhage by diapedesis, degenerative necrotic change, and etc. And electrocardiographic change and laboratory diagnostic markers we use, and the troponins, the creatine kinase, maybe atypical types of the myocardial infarction as well, abdominal, asymptomatic, and etc. For example, some patients they go to the gastroenterologist for the stomach ache. After the checking, the physicians they diagnose the myocardial infarction, cardiologists. The outcomes of the myocardial infarction patients. Hospitalized patients where the angiography, echocardiography, and perfusion scintigraphy are available. Usual fate are first, about 25% of patients die of cardiogenic shock or fetal arrhythmia. Patients who survive the acute phase may develop the congestive heart failure, cardiac arrhythmia, left ventricular failure with pulmonary edema, rupture of ventricular wall, interventricular septum, and papillary muscle thromboembolism. 10-20% patients recover with no complications, and early restoration of blood flow by thrombolysis or balloon angioplasty provides better prognosis. The diagnosis of the myocardial infarction based on symptoms, electrocardiographic change, and serum elevation of myocardial enzymes, that creatine kinase, MB isoenzymes, or the other proteins, that troponin I, troponin T, or myoglobin that leak out of dead cells. The classic electrocardiographic finding is the normal PQRST complex, but in the myocardial infarction, especially in the transmural infarction, we found the elevation of the ST complex, and in the subendocardial ischemia, the depression of the ST segment. Complication of the myocardial infarction that depended on the size, location, duration of the lesion. Within minutes to 3 days of onset, arrhythmias develops. That's 75 to 95%. The ventricular fibrillation, block of the atrioventricular bundles, and its branch causing acute heart failure. Then cardiogenic shock in the 10-15%, usually in large impact, causing acute heart failure. Thrombotic complications, the 15-40% mural thrombus over infarct area or atrial thrombus, causing embolism of brain, kidney, etc., and rupture of the heart. In 3 to 14 days, the large infarcts, there is softening of dead muscle, myomalacia cordis, leading to rupture and death. Site of rupture in ventricular wall, papillary muscle, and interventricular septum. Acute fibrosis or hemorrhagic pericarditis over infarct area. After weeks or months, it develops a chronic heart failure and cardiac aneurysm, which may rupture, producing hemopericardium and death. Here are some illustrations about the gross view of myocardial rupture, the myocardial aneurysm with thrombosis inside, left ventricular aneurysm containing the mural thrombus, and left ventricular aneurysm, you see the very thin white wall of the aneurysm toward the apex here. Then the ventricular wall rupture into the pericardial cavity can produce the life-threatening cardiac tamponade. And microscopically, we see the mesothelial epithelium that cover the pericardium and the hemorrhage beneath the mesothelium that we call the hemorrhagic pericarditis. Chronic ischemic heart disease or the ischemic cardiomyopathy occurs during cardiac forms of atherosclerosis and hypertension. Atherosclerotic cardiosclerosis and arteriosclerotic cardiosclerosis they cause the chronic ischemic heart disease. And during this disease develops the chronic hypoxia and the small foci in perivascular spaces, diffuse development of the connective tissue between cardiac muscle cells as thin septa and bands that they leads to the formation of the sclerosis. The cardiac muscle cells are not destroyed. They are atrophied because pressed out of the environment. Lipofuscinosis can occur in cardiomyocytes. Here you see the atherosclerosis in the proximal left interior descending coronary that removed from the heart, that these patients had mild to moderate atherosclerosis to the coronary arteries. And here you see the diffuse cardiosclerosis or diffuse atherosclerotic cardiosclerosis. Another disease is the diffuse small focal cardiosclerosis, as we call the interstitial fibrosis of myocardium, angina pectoris in clinic, chest pain, the crushing, squeezing, pressing pain in the interior chest and maybe referred in neck and jaws, the left arm and the upper abdomen that are relieved by nitroglycerin. Types of the angina pectoris, there are three types: the stable angina, the most common patterns, that caused by any additional stress and increasing function of the heart. Prinzmetal angina classically occurs at rest and is caused by reversible spasm in normal to severe atherosclerotic coronary arteries, and unstable angina characterized by prolonged pain. It was the clinical features of the diffuse small focal cardiosclerosis that they developed after regarding the atherosclerosis and the hypertension. Now let's discuss the post-infection large focal cardiosclerosis. Represent the healing process of infection focus in myocardium, occurs to the replacement of necrotic heart muscle by fibrosed tissue. Microscopically, we see the large area of whitish firm scar tissue. Microscopically, formation of the scar tissue may lead to chronic cardiac aneurysm. This in post-infection cardiosclerosis occurs for two reasons. First, the sudden heart death due to the severe disorders in conducting system of heart and chronic heart failure. Here is the post-infection large focal cardiosclerosis, the gross view in the wall of the heart, and the microscopically we see the formation of the scar tissue in the heart. And the key points for the prevention of the ischemic heart disease: get regular medical checkups, control your blood pressure, check your cholesterol, do not smoke, exercise regularly, maintain a healthy weight, eat a heart-healthy diet, and manage stress. Now let's discuss about the cerebrovascular diseases and the pathology of the cerebrovascular diseases. The term cerebrovascular disease includes all disorders in which an area of the brain is temporarily or permanently affected by ischemia or bleeding, and one or more of the cerebral blood vessels are involved in the pathological process. Disease of the cerebral blood vessels equal atherosclerosis of the cerebral arteries and cyanosis of cerebral arterioles and hypertension, and commonly called as the cerebrovascular disease. The disease accounts for 10% of all deaths. The direct causes of cerebrovascular disease: the prolonged spasm of cerebral vessels, especially arterioles and small caliber arteries, thrombosis in cerebral vessels, thromboembolism of cerebral vessels, as well as internal carotid and spinal arteries, and rupture of cerebral arterioles that have lost their elasticity due to hyalinosis during a hypertensive crisis. There are three groups of the cerebrovascular disease: the ischemic cerebral stroke, hemorrhagic cerebral stroke, and hypertensive pre-stroke change. The ischemic cerebral stroke, it used to be called the cerebral infarction. Ischemic cerebral stroke is a necrosis of any part of the cerebral cortex due to abstraction to the intracerebral and precerebral arteries as a result of thrombosis and thromboembolism. Ischemic stroke is more common than hemorrhagic stroke. It occurs most often in the gray matter of the cerebral hemispheres and in the area of the subcortical nuclei. It is usually occur due to cerebral ATHEROSCLEROSIS and sometimes occur in thromboembolic syndromes and when the cerebral vessels are constricted from the outside. The ischemic cerebral stroke has three types: the ischemic cerebral infarction, hemorrhagic cerebral infarction, and mixed cerebral infarction. Ischemic cerebral infarction more common, making 3/4 of other types of infection. The liquefactive necrosis develops there, that they surrounded with the demarcation zone after 2-3 days, and here the macrophage infiltrated here and they start the engulf of the products of the decomposition of the lipids and the myelins, and we call this macrophage that lipid-laden macrophage that seen in the histologic slides as the granular balls. Macroscopically, it is the white infection. The area of the brain becomes pale and swollen, sticks to the knife when cut, becomes less elastic. The consistency is rough and doughy. The color is whitish gray. The area of infection gradually softened to the liquefactive necrosis. We call the gray or the white softening of the brain. Necrosis gradually undergoes hydrolytic autolysis and the cyst forms in its place. The cyst is covered with a thin whitish gray capsule on the outside. If the site of ischemic infection is small, sometimes a glial scar may remain instead of a cyst. Here you see the cerebral infection in the 2 weeks and the cerebral infarct 1 to 4 weeks. And the histology of the ischemic cerebral infection we discussed before, that these are the granular balls or the lipid-laden macrophage that they engulf the myelins and the products of the destructions. And here you see the glial scar, the reactive astrocytes that they form the glial scar in the brain. The late cerebral infection, here you see the cyst formation with the hemosiderin, and the microscopically you see the cyst formation. There is the brain tissue and the lumen of the cyst. Hemorrhagic cerebral infection, relatively rare. It usually develops in the cerebral cortex as a result of cerebrovascular thromboembolism, and very rarely in the area of the subcortical nuclei. First here forms also the white infection, but after the hemorrhage to the site of the necrosis, it became to the red infection. The bleeding develops a few days after an ischemic infection due to the secondary necrotic change in the blood vessels in the area, and it is diabetes. At the site of hemorrhagic infection, a red softening of the brain occurs and remains a cyst with rusty wall. Third types of the ischemic cerebral stroke is mixed cerebral infection. Here you see the hemorrhagic cerebral infection, the gross view of the hemorrhagic infection. Also the cyst formation, the same picture you see. Hemorrhagic cerebral stroke. It is an acute circulatory disorder characterized by cerebral hemorrhage. It most often occurs during hypertensive crises. There are two types of the hemorrhagic cerebral stroke: hematoma, hemorrhagic impregnation, and subarachnoid hemorrhage. Hematoma, it accounts for 85% of hemorrhagic strokes, and here develops the red softening of the brain. In the following days, mainly glial cells and the siderophage appears in the peripheral parts of the hemorrhage. Blood clots and the destruction products begin to absorb and forms the cyst. The gliosis reaction turns into the thin capsule. The inner surface of the capsule is rusty as a result of hemolysis of red blood cells and local hemosiderosis. The liquid contents in it is grayish. It is usually found in the subcortical nuclei and in the cerebellum. In large hematomas, blood can also enter the brain ventricles, resulting in the death. Here you see the schematic illustration of the brain hematoma, that subdural hematoma, intracerebral hematoma, epidural hematoma, and the gross view of the hematoma, or we call the hypertensive intracerebral hemorrhage. Hemorrhagic impregnation occurs in the brain against the background of hypertension and during hypertensive crises. It occurs as a result of massive diapedesic bleeding from the vessels as the petechial hemorrhage. The erythrocytes enter between the neurons in the perivascular spaces and penetrates the brain, and neurons are necrotized. Unlike hematoma, the borders of the stroke focus are not clear during hemorrhagic impregnation. Macroscopically, the separate small foci of hemorrhage appears to be connected to each other. In the place of these foci, the red softening of the brain occurs later. Hemorrhagic impregnations usually occur in the area of the subcortical nuclei. And final disease of the hemorrhagic cerebral stroke, the subarachnoid hemorrhage. The synonym non-traumatic or spontaneous subarachnoid hemorrhage. It is found at the age of about 65. Causes: occurs as a result of rupture of relatively large caliber arterial and or arteriovenous aneurysm in the pia mater, tumors or tumor-like lesions of pia mater vessels, small chorea, systemic vasculitis, leukemias, hemorrhagic meningitis of various infections, origins, intoxications, and etc. And 25% of the subarachnoid hemorrhage of unknown origin. Here is the gross view of the subarachnoid hemorrhage. The third group of the ischemic, cerebrovascular disease is hypertensive pre-stroke change. First of them is hypertensive encephalopathy, or the transitory ischemia. It is characterized by acute ischemic change in the ischemic cerebral artery itself, in the perivascular areas, and in the brain substance corresponding to these vessels during a short-term hypertensive crisis. When the crisis is long-standing, and our aneurysms forms in the vessel wall, resulting in a hematoma. Perivascular edema, small foci of diapedesic hemorrhage appears. Acute ischemic and hypoxic change, pericellular edema occur in the brain tissue, ischemic degenerative change found in some groups of neurons. These changes are temporary and reversible. We call the transitory cerebral ischemia. Local hemosiderosis occurs at the site of perivascular diapedesis. The clinical features of the hypertensive encephalopathy: temporary signs of acute cerebrovascular disorders and some mild local paralytic complications are found. is characterized by severe headache, nausea and vomiting, papillary edema, visual disturbances, seizures, confusion, and severe cases coma. It occurs most often in the cells of the second, third layers of the cerebral cortex, in the somatic and vegetative nuclei of the medulla oblongata. Lacunar change in the area of the subcortical nuclei, especially in the perivascular areas. There are small cysts showing old diapedesic hemorrhage and rust-colored walls. Subcortical leukoencephalopathy. In the area of subcortical nuclei, axons of neurons and their myelin sheaths are destroyed, and hyalinosis develops in the wall of arteries. Here is the microscope of hypertensive encephalopathy. Here you see the fibrinoid necrosis of a small artery and the fibrinoid necrosis of arterioles in the basis pontis. This is the special staining. The phosphotunzic acid hematoxylin stains show the fibrin. Thank you very much for your attention.